Welcome to this episode of Healthcare Watchdog, where we look at important public health care issues that could affect you and your family. We do the research and you decide what is the best course of action for you and your family members when it comes to public health recommendations. This episode will deal with evidence-based practice, also known as evidence-based medicine. What is it? Why is it essential to your health? And most importantly, how does it enable the average consumer to assess healthcare recommendations in the news or made by public health officials, such as the Director of the Centers for Disease Control and Prevention, the CDC, whose guidelines is followed throughout the country? To understand evidence-based practice, one begins with three historical figures: Florence Nightingale, Archibald Cochrane, and David Sackett. Florence Nightingale came from a wealthy British family. She was a highly educated British nurse who was also an accomplished statistician. She made an indelible mark on the future of healthcare during the Crimean War between Britain and Russia, when she was recruited to manage the nursing staff for injured British soldiers in Constantinople. When she arrived, she discovered horrible conditions. Nightingale found soldiers being treated on the floor with a shortage of supplies, a broken sewer line, inadequate ventilation, and inefficient laundry and kitchen. She and her staff were efficient and improved the laundry and food service and the skills to establish the first school of nursing. She took meticulous notes and applied her statistics skills to track the causes of death, making her efforts the first clinical study with statistical analysis. She calculated the monthly mortality rate at 40% and discovered that most of the deaths were from preventable infections and other diseases, not war wounds. She created a polar graph, which is like a pie chart, but much better as it incorporates a timeline and a stacked bar graph. Two charts covered the monthly fatalities at the Scutari Hospital from April 1854 to March 1856. The initial chart convinced the British government to send a sanitation commission to Scutari Hospital in March 1855 to repair the sewer line and the ventilation. The second chart showed the dramatic reduction in death rate from 40% to 2% after the commission did its work, validating the value of statistical analysis and sanitation in public health for all future generations. Her polar graphs are seen in the figure. Notice the large dark areas on each slice. They represent deaths from non-combat conditions, usually infections. Notice the shortened slices after March 1855, which show the reduction in deaths after the Sanitation Commission did its work. This polar graph dramatically changed how soldiers were treated in wartime. Archibald Cochrane is considered one of the pioneers of evidence-based medicine. He also had a personal story like Florence Nightingale that led to historic changes in the practice of medicine. He was part of the British Army in World War II and was captured by the Germans. While in captivity, he discovered that most prisoners developed an unusual swelling in the ankles. He hypothesized that it was due to a nutritional deficiency. He created a randomized controlled trial, known as RCT, by separating the prisoners into two equal groups. One group would take yeast to address the presumed deficiency, and the others would not. This RCT meets the definition of a controlled experiment, where the researcher controls the variable, here, yeast ingestion. He calculated water intake and output. From this first randomized, controlled trial, he determined that the prisoners who were given the yeast improved while the other group did not. His experiment result was so compelling to his captors that the Germans provided yeast that was in short supply during the war. This experiment led to pioneering work in RCT, which remains the gold standard as the highest quality of evidence that yields the most reliable results. He established the Cochrane Library, also known as the Cochrane Collaboration, in 1993, where strict criteria are used to review all available research on a subject and submit to meta-analysis, the absolute top rungs on the research quality ladder. Cochrane Library is now the most extensive and sought-after study in 130 countries and has more than 50,000 collaborators. After 5,000 publications, the Cochrane Library is the basis for most World Health Organization guidelines worldwide. Evidence-based medicine can be defined as making healthcare recommendations for the patient, not simply based on the doctor's opinion, but rather based on the best available research evidence as well as the patient's desires. A systematic and detailed approach to the current research is required to achieve this goal.
You're being acknowledged for your work on evidence-based medicine.
Yes.
What is that term?
That is a natural outgrowth of clinical epidemiology that has three elements. The first and most important is the patient. What is their problem? How do they see their problem? What are their expectations? What do they want to get out of the transaction? The second is your own clinical skills. You got to be a good doctor. You have to be very good at diagnostics and sorting out exactly what's going on. And then the third would be the evidence that you draw upon to make decisions about that patient's therapy. And putting all those three together is what we call evidence-based medicine.
If there's an evidence-based approach, I presume there is another based approach. What else could there be?
Well, in medical history, those sorts of decisions have usually been based on simply observing patients. Who did well, who didn't do well, and what did they receive? And the problem with those sorts of observations is that if a patient's going to die, you can give them a lethal treatment and you'll never notice. If a patient's going to get better, you can give them any sort of treatment and the treatment will look effective.
Dr. Cochrane developed a systematic process for reviewing medical evidence to establish best practices. David Sackett made the practice of medicine a, quote, team sport, unquote, linking the field of epidemiology, primarily focused on public health, to clinical practice. He coined the famous statement that evidence-based medicine, known as EBM, was, quote, the conscientious, explicit, and judicious use of current best evidence in making decisions about the care of individual patients, end quote. This requires much more than, quote, expert opinion, end quote, which occupies the lowest rung in the quality of evidence. Dr. Sackett did not like being called an expert because he indicated that the term gave too much weight to a person's opinion and that the reliance should be on the best information available, not just individual thought. By joining research to clinical practice, he originated the best medical practice guidelines, now found in all healthcare areas, including nursing and therapy practices. One noteworthy statement he made was, quote, because I was an expert, my opinion had an added weight it didn't deserve, and it cut off the conversation, end quote. His goal was to direct physicians to apply evidence from the best quality research to reach their patient's best treatment plan. Again, this differs from an unqualified expert opinion commonly seen in healthcare policymakers and consultants on the news where no authoritative research is provided. Dr. Sackett was one of 13 authors of a 1985 paper that demonstrated that patients with unstable angina who take aspirin would have a lower rate of cardiac death and non-fatal heart attacks, affecting the future health of millions of people. Dr. Sackett developed a hierarchy of evidence evaluation that is in use today, separating medical evidence from low-quality observations to high-quality RCT. The 5 levels begin at the bottom with single-case reports and expert opinion, reaching the top level with randomized clinical trials, which are classified as experiments and then systematically reviewed using a rigorous multi-step process. All available qualifying studies must be evaluated to qualify as top quality, whereas the doctor or researchers at the bottom can pick and choose. The Cochrane Library is the best-known systematic review collaboration. Sackett's Pyramid of Evidence shows the levels of medical evidence quality. It ranks the evidence based on the steps required to obtain reliable results. The lowest rungs of the pyramid show the lowest quality evidence, and includes simple expert opinion, which is used daily in medical practice with variable research support. The highest rungs of systematic review and meta-analysis represent the highest quality evidence because it is the most complex, time-consuming, and rigorous effort is required, along with a particular step-by-step protocol, but it provides the best available medical evidence to treaters and policymakers if they use it. It is essential to understand the difference between qualitative and quantitative research. Qualitative is merely an observational review, such as expert opinion from observing one or more patients, and is primary evidence. However, quantitative research subjects the data to specific statistical analysis. Qualitative studies are purely subjective based on the researcher's perceptions. At the same time, quantitative reviews are strictly objective, requiring statistical analysis. Therefore, editorials and expert opinions are qualitative and lower-level subjective evidence, whereas randomized controlled trials are quantitative and therefore much higher quality and more reliable outcomes. Systematic reviews with meta-analysis used for clinical practice guidelines are considered secondary sources because they take all the primary evidence, systematically review all the quality studies, and analyze the evidence to reach the most valuable conclusions. Secondary evidence occupies the highest levels of the pyramid and is the most valuable, but it is also the most expensive, time-consuming, and rigorous, making secondary evidence the least common in medical literature. No study is perfect, but if you come across a review from the Cochrane Library or an article that states it used the Cochrane Protocol, you can be guaranteed to get top-level results that your doctors can rely upon with confidence. Hence, doctors and government policymakers who study systematic reviews provide patients and public health agencies with the best quality, evidence-based recommendations because they combine their training, background, and experience with the highest levels of current research evidence available. The following excerpts from CNN interviews with the two top COVID-19 policymakers that follow without using secondary evidence are examples of the lowest pyramid-level expert opinion. We research, you decide.
There's an uptick in COVID cases and a new variant called BA.2.86, some 3.5 years since the pandemic was first identified. But if public health officials feel it necessary to ask America to mask up again, how many would comply? According to Gallup, in the first 2 years, public confidence in the U.S. healthcare system has dropped from 44% to 34%. Joining me now to discuss is Dr. Anthony Fauci. He, of course, is the former director of the National Institute of Allergy and Infectious Diseases. There is a perception out there by many, how many I don't know, that they don't work and that the data concludes that they didn't work in the first go-round. Respond to that on masks.
Yeah, well, that's not so. I mean, when you're talking about at the population level, that the data are less strong than knowing that if you look on a situation as an individual protecting themselves or protecting them from spreading it, there's no doubt that masks work. Different studies give different percentages of advantage of wearing it, but there's no doubt that the weight of the studies, and there have been many studies, indicate the benefit of wearing masks.
I'm going to refer to one of them. You've heard about it before. I heard about it from a number of radio callers. Brett Stevens in the Times talked about Cochrane. Put that on the screen. The most rigorous and comprehensive analysis of scientific studies conducted on the efficacy of masks for reducing the spread of respiratory illness, including COVID-19, was published last month. Its conclusions, said Tom Jefferson, the Oxford epidemiologist who is the lead author, were unambiguous. There is just no evidence that masks, make any difference. He told the journalist Mayan Damasi, full stop. But wait, hold on. What about the N95 masks as opposed to the lower quality surgical or cloth masks? Makes no difference. None of it, he said. Well, what about the studies that initially persuaded policymakers to impose mask mandates? They were convinced by non-randomized studies, flawed observational studies. How do we get beyond that finding of that particular review?
Yeah, but there are other studies, Michael, that show at an individual level for individual. When you're talking about the effect on the epidemic or the pandemic as a whole, the data are less strong. But when you talk about as an individual basis of someone protecting themselves or protecting themselves from spreading it to others, there's no doubt that there are many studies that show that there is an advantage. When you took at the broad population level, like the Cochrane study, the data are less firm with regard to the effect on the overall pandemic. But we're not talking about that. We're talking about an individual's effect on their own safety. That's a bit different than the broad population level.
CNN's Dana Bash tried to get CDC Director Walensky to explain her mixed messaging regarding who needs to be masked and who doesn't.
Yeah, and I understand what you mean about a first step, but can you see, since this is big news for every American, can you see how your guidance that vaccinated people can take their masks off, but requirements from businesses, local governments to keep the masks on are sending a mixed message?
Here's what I know. I know that we need to do the hard work. This was individual guidance to understand what this means for communities, what this means for businesses. We know at the individual level, the vaccinated people are safe. More than 1/3 of Americans have been vaccinated, over 45% of adults above the age of 18. Those people are safe when they get vaccinated, after they're fully vaccinated. For those who are unvaccinated, we're really asking those businesses to work hard to make sure that they have available vaccine for those people so that they have time off, so paid time off, so that they can get their employees vaccinated. Mm-hmm. And for those people, we really are asking them to get vaccinated or wear masks to keep themselves safe.